development of heart. Now, development of heart, it begins from the lateral plate mesoderm. Let me show you where exactly you find this one here. Now, for example, if this one here will be the ectoderm, and if this is the endoderm and the mesoderm in the middle, and if this one here will be the notochord. So this is actually the transverse section of embryo in the 3rd week of development. So ectoderm, endoderm and mesoderm, and this one here will be the notochord. Now in the 3rd week of development, the mesoderm, that is your intra-embryonic mesoderm, is in turn divided into like 3 parts here. The one which is just adjacent to the notochord here, it is the one which is traveling like parallel to the axis of the embryo. So that is why this one here will be the paraxial mesoderm. This is paraxial mesoderm here. And then in the middle, you'll be having intermediate mesoderm here. So suppose this one to be the intermediate mesoderm, and then you'll be able to appreciate one more here. This will be the lateral plate mesoderm. So in short, we can say that the mesoderm, intra-embryonic mesoderm, the mesoderm present inside the embryo, it's divided into like 3 parts here. Number one, which is just adjacent to the notochord here. This one here will be the paraxial mesoderm. And just adjacent to that one will be the intermediate mesoderm in the middle here. And then you'll be able to appreciate the lateral plate mesoderm. And this lateral plate mesoderm, inside that there is a formation of intra-embryonic coelom. Now because of that coelom, it is in turn divided into splanchnopleuric and somatopleuric. So there will be somatopleuric lateral plate mesoderm, which is along the ectoderm, and splanchnopleuric lateral plate mesoderm, which will be along the endoderm. And splanchnopleuric lateral plate mesoderm is the one from where exactly your heart is actually developing. So I repeat again, your heart formation begins from the splanchnopleuric lateral plate mesoderm. Now, during the formation of the heart, initially there will be 2 endocardial primitive heart tubes. There will be 2 heart tubes present there. So they are like primitive heart tubes, endocardial, and these 2 heart tubes are going to fuse together. And please remember, they are going to fuse cranially, whereas their caudal ends are going to remain totally free. The fusion will be cranially here. You can appreciate here, but their caudal ends will be remaining free. Now, once they are fused together, now further what is going to happen in this heart tubes, there will be formation of 3 dilatations here. Now, we are going to discuss about the 3 dilatations later on. First, let us see the cranial part and the caudal part. Now, in this heart tubes, after the fusion, the cranial part will be referred to as truncus arteriosus. It's very, very much important. Please learn this term right now. Repeat this term in your minds right now and learn that. The cranial part of the heart tubes is referred to as truncus arteriosus, whereas the caudal part is the one which will be referred to as sinus venosus. That will be sinus venosus. So I repeat again, after the fusion of the heart tubes, the cranial part is actually referred to as truncus arteriosus and the caudal part will be referred to as sinus venosus. Now from the name itself, we can understand that sinus venosus, venous, it is the one which is going to drain the blood. So that is going to be the inflow part of this one here. Whereas truncus arteriosus, artery, from here the blood is going to move out of the heart. So that will be the outflowing part. Now my dear doctors, if you learn this basic concept, a lot of things will be cleared. So please remember, sinus venosus, it will be the inflowing part. The blood is going to enter from there. Truncus arteriosus will be the outflowing part, sir. Outflowing part. Now, if truncus arteriosus is actually the outflow part, now try to correlate the embryology with our body right now. I mean to say gross anatomy. Now, in your body and my body, whenever our heart is going to pump the blood is going to move out via ascending aorta. Okay, and number 2 from the pulmonary trunk. So pulmonary trunk is going to begin from your right ventricle, whereas aorta is going to begin from your left ventricle, and from here the blood is going to be taken out of our hearts. So that is going to be acting like an outflow. So if aorta and pulmonary trunk is going to form like outflow, now you can easily correlate with embryology. It has to be derived from the truncus arteriosus. So the first point that we are learning here is truncus arteriosus is the one which is going to form, number 1, ascending aorta, and number 2, please remember, pulmonary trunk. Please be very careful. I'm telling pulmonary trunk here, not the pulmonary artery. So ascending aorta and pulmonary trunk are derived from truncus arteriosus. Now, Now from the heart, all the cardiac veins are going to drain the blood into coronary sinus, and coronary sinus is going to drain the blood into right atrium of the heart. So now I'm telling you about the inflow part. So who is the hero of the story here? Coronary sinus. All the cardiac veins will be finally draining the blood into coronary sinus, except the anterior cardiac vein we have learned in the venous drainage of the heart. So please remember the important term, that is coronary sinus. Now if that is acting like an inflow, that has to be derived from where? Sinus venosus. Because sinus venous is acting like an inflow part here. So therefore coronary sinus has to be derived from sinus venosus. But one thing important to learn here, as I told you, only they'll be cranially fused, guys. The heart tubes are fused cranially, but their caudal ends are going to remain free. And if they are free, this will be like right horn, and another one will here be left horn. And out of these two horns, please remember left horn. Left horn is the one which is going to form the coronary sinus. Left horn is the one which is going to form coronary sinus. In fact, remember, later on you'll be able to understand that the left horn of the sinus venosus will actually degenerate. So coronary sinus is actually a remnant of that one. To be very, very specific, it is a remnant of the left horn of the sinus venosus. Now once you are done with the cranial part and the caudal part, as I told you, in the middle you'll be having like 3 dilatations here. In these heart tubes you'll be having 3 dilatation. Dilatation number 1 here, it is referred to as bulbus cordis. Dilatation number 2, this one is primitive ventricle here, and this one here is primitive atrium. And look how meaningful this one is. All the blood which is going to drain, finally it will be entering into atrium. Now when the atria will contract, the blood will go into the ventricles, and from the ventricles the blood is actually going out into the ascending aorta and the pulmonary trunk. Absolutely makes sense here. So therefore, whatever these 3 parts are present here, bulbus cordis, primitive ventricle and primitive atrium, they have to form your chambers. So they are the one which are going to form the atria and the ventricle.
Important thing in cardiovascular system that you have to read is the pressure volume loop or the PV loop in the cardiovascular system. So from the name, as you can understand, that x-axis will be the volume axis and y-axis will be the pressure axis. So during different phases of the cardiac cycle, if you plot the change in volume and pressure, then that is known as the pressure volume curve in the cardiovascular system. Generally, this curve can be plotted for the right ventricle also, separately for the left ventricle also, but generally we prefer to plot the left ventricular pressure volume curve. So in x-axis, first I am drawing one line here. So this line, suppose I am giving name, this is A to B. So A to B is a phase where the ventricular filling is going on. So in the ventricle is in relaxation, or in diastole, the ventricular filling is going on, and because of the ventricular filling, the pressure is rising within the ventricle, but that rise of pressure is very, very slow. That is the meaning of this line. So this A to B line, so this is A to B, this is the filling phase of ventricle, filling phase of ventricle. Now, whenever the filling is complete, the B point, this is the point where the volume which is present in the ventricle is known as the end diastolic volume. So, when the ventricle is filled with end diastolic volume, the ventricle will contract. The first phase of ventricular contraction is isovolumic contraction phase. So, from B to phase C. So, B to phase, B to C, this is known as the isovolumic contraction phase. So what happens during isovolumic contraction phase? As you can see here, the volume within the ventricle is remaining same, that is the same end diastolic volume, but the pressure is rising to a very high level. So this is isovolumic contraction phase. At the end of the isovolumic contraction phase, the ejection will start. So ejection means the ventricle is ejecting blood in the arch of aorta. So what is going to happen? Initially, the pressure will rise a little bit in the ventricle, followed by there will be decrease in pressure in the ventricle. But if you look at continuously, the blood volume within the ventricle is decreasing. That is because of the ejection. So suppose this C to D is the which phase of the ventricular cycle? This is known as the ejection phase of cardiac cycle. This is the ejection phase of cardiac cycle. Now at the end of the ejection, when the ejection is done, ventricle will go for relaxation. The first phase of relaxation or the diastole is known as the isovolumic relaxation. So from this D to A, so D to A, this phase is known as the isovolumic relaxation phase. Isovolumic relaxation phase. Why this is isovolumic relaxation? If you look at here, the volume is remaining same. Okay, but the pressure is decreasing to a very low level. That is because of the relaxation of the ventricle, and the volume is remaining same. What is the name of this volume which is present at this point number A? This is known as the end systolic volume. So at the end of systole, the volume which is remaining, because this is the ejection phase. After the ejection, the remaining volume which is present in the ventricle during isovolumic relaxation, that is the same volume, that is known as the end systolic volume. All of you know that if you subtract from end diastolic volume to end systolic volume, what volume you are going to get? You are going to get the stroke volume. So this is a loop. This loop is known as the pressure volume loop, different phase of the cardiovascular system. Now you look at point number B, whenever the ventricle is starting its contraction, the first phase of systole, that is isovolumic contraction, which valves is going to closed? So ventricle is contracting, means isovolumic contraction means all the valves is going to close. But at point number B, the valves which is going to closed is the closure of the mitral valves, closure of mitral valve. So if you think of the right ventricle, the closure of the tricuspid valve will be there. So this is the point where the first heart sound is going to happen, right? And then you can find out that isovolumic contraction is going on. At point number C, the ejection phase is starting. For the ejection to start, which valve should has to be open? So this is the point where there is going to be opening of semilunar valves, or you can say aortic valve opening. So right ventricle means pulmonary valve is going to open. Now at point number B, this is the beginning of the isovolumic relaxation and ending of the ejection phase. So at the end of the ejection phase, what valves you have to close? So there will be closure of the opened aortic valve. So closure of the aortic valve is going to happen in this phase, right? So aortic valve closure means pulmonary valve is also going to close. So this is the point where the second heart sound is going to happen. And then at the end of this isovolumic relaxation, this point number A is the beginning of the filling phase of ventricle. So beginning of the filling phase of ventricle means you have to open a valve. Which valve has to be open for filling of the ventricle to be started? That is the mitral valve opening. So this is the point where the opening of the mitral valve is going to happen, right? So after the opening of the mitral valve, whenever the ventricle is filled with the end diastolic volume, again there will be closure of the mitral valve, and this pressure volume loop will continue.
Either there's right-sided heart failure or left-sided. Now if the right side of the heart will fail, as I am highlighting over here, normally right side of the heart receives all the venous blood, superior vena cava, inferior vena cava. If the right side of the heart has failed, this means all the blood is now going to go back into two main organs, that is going to be the liver as well as the spleen. So in the liver, when there is, what will I say, all the venous blood has gone, chronic venous congestion has gone in the liver. So chronic venous congestion of the liver will look like this, that is the nutmeg liver. You can see over here all those congested areas, they are looking a little darker. So you have dark areas and then you have lighter, paler areas. This alternating dark and light is the nutmeg liver seen in CVC liver. The same blood will also go into the spleen, so that is going to result in CVC spleen. And you all know that whenever there is a lot of blood, what is the pigment formed from blood? From blood there is going to be a lot of hemosiderin. So if someone asks you that because of CVC in the spleen what is formed, hemosiderin is formed, and that is known as gamma antibodies. Gamma antibodies are made up of blood products like hemosiderin. On top of that, some calcium goes and gets deposited. So the actual composition of gamma antibodies, first a blood product hemosiderin, on top of that calcium deposits. So these are the two findings. CVC liver is nutmeg liver, CVC spleen shows me gamma antibodies. Why did venous congestion happen? Because the right side of the heart had failed. Now let's go to the other side. If the left side of the heart ends up failing, now why would that happen? One of the very common causes is going to be hypertension. If the left side fails and it's not pumping blood forward, then by back pressure, where is the blood going to go? It is going to go and affect the lungs. So they ask you, which is the organ affected? Imagine blood is going into the lungs. Pulmonary congestion, the lungs are going to become extremely wet and boggy. They will not be air-filled organs. They will, because of pulmonary congestion, there will be a lot of heaviness in the lungs, and radiologically we see the classical Curley lines which you must have seen as well. But my concern over here is that when all of this blood and this pulmonary congestion is happening in the lungs, from the blood you always know which pigment comes out. hemosiderin comes out. So actually this is an image that we've got from the lungs, orienting you. These empty spaces are the alveoli, but they are no longer empty. I can notice these alveoli are actually filled with this brown color material, which is hemosiderin because of pulmonary congestion. This is hemosiderin which has actually come in, and whenever something comes, one cell will always go and eat it up, which is macrophages, right? So can I say that I have resulted in the formation of heart failure cells? What are heart failure cells? They are actually macrophages which have eaten up what? Hemosiderin. Hemosiderin laden macrophages are the other name for heart failure cells. Which heart failure are they seen in? Left-sided heart failure. And in which organ are they seen? They are seen in the lungs. Three things if I have to give you a take-home message. In right-sided heart failure, CVC liver is nutmeg liver, CVC spleen is gamma antibodies. In left-sided heart failure, there is going to be pulmonary congestion, so heart failure cells are seen.
Now let's talk about drugs for CHF, that is chronic heart failure, in which the heart is becoming damaged and the cardiac output is getting reduced. So the first class of drug we give in CHF is to protect heart, cardioprotective drug. And cardioprotective drug, remember, they decrease mortality and these drugs can increase the life of a person. Then we have symptomatic relief. So in left ventricular failure, the patient will have pulmonary edema because of increase in preload, and because of increase in afterload artery constriction, patient can have hypertension. And lastly, we use inotropic drug which will increase cardiac output if the patient is having heart failure with reduced ejection fraction. That means when the cardiac output is reduced. So let's see what are the cardioprotective drug we have which can reduce mortality are sahibs. So we can remember a mnemonic sahibs. Only these are the cardioprotective drug we have in CHF. So the first drug we have is sacubitril. It is given in a combination with valsartan, and this combination is known as ARNI, that is angiotensin receptor blocker and neprilysin inhibitor. We will come back to this drug shortly. The overall drug of choice or the first drug to be started is ACE inhibitor, pril or sartan wale drug. We can also give aldosterone blockers like spironolactone or its brother eplerenone. They have cardioprotective effect. Hydralazine and ivabradine also have cardioprotective effect. Beta blockers are cardioprotective drug in CHF, but remember there are only 4 beta blocker which can reduce cardiac mortality, that is NBMC, which stands for nebivolol, B for bisoprolol, M for metoprolol, and C for carvedilol. So only 4 beta blockers are approved in CHF which can reduce mortality, and the last new class of a drug which was initially approved for diabetes mellitus are also approved in CHF. Again, they are SGLT2 inhibitor. These drugs are ending with the word gliflozin like canagliflozin, dapagliflozin, empagliflozin. So these drugs also reduce mortality in CHF. Now to reduce edema and hypertension, we give diuretics and vasodilator. So overall drug of choice is loop diuretic, but yes, you can also use thiazide diuretic. Which diuretic is absolutely contraindicated in heart failure? That is mannitol. Because mannitol rather increase preload, it rather causes pulmonary edema. Nitrates and neseritide is also given. So what is this neseritide? We will come back to it shortly. So it is a synthetic form of BNP, that is brain natriuretic peptide. And lastly, the only inotropic drug which will increase cardiac output approved in CHF is digoxin. So remember, digoxin has no mortality benefit. It is not a cardioprotective drug.
If he says what is the earliest ECG finding in myocardial infarction, then don't answer ST segment changes, which is one of the common mistakes that a lot of people do. One of the earliest ECG findings should be answered as hyperacute T waves, which simply means that there is an increase in the vertical height of the T wave from the standard 5 mm in the limb leads. And this is anyway not to be mixed with even the tall tented T waves, which we encounter in patients with hyperkalemia. Now, if he says which ECG finding will persist for whole life of our patient, You see, suppose somebody at COVID time, because you're aware that COVID virus was contributing to a hypercoagulable state and was increasing the incidence of MI. So those patients who had MI in 21 or 22 post-COVID, they, even if come to us today, would be having presence of deep Q waves, which indicate cell death. The point to be remembered is that in myocardial infarction, the findings that happen would go back to normal with treatment. Like if we are having a ST segment elevation of 3 millimeter, 2 millimeter, whatever, this ST segment change will come back towards normal. But one finding that will never ever come back is the deep Q wave present. Now, what is the first cardiac biomarker to rise in myocardial infarction? When this question came initially, there was a lot of, I can say controversy and bloodbath with respect to it. One I can say is that myoglobin is a good answer, but then myoglobin can rise due to damage to the skeletal muscle. Like suppose patient needed a DC shock because patient went into an arrhythmia. Now, when I give a DC shock to the patient, the current will go through the skeletal muscle, and the damage to the skeletal muscle can also cause myoglobin values to rise. So I will not be sure whether the myoglobin is coming from the cardiac tissue or whether myoglobin is coming from the skeletal muscle injured due to the DC shock. So we will always be looking for a marker which goes beyond myoglobin, and that would be ischemia modified albumin. Last to rise in MI is obviously LDH, so nobody will bother about it. But then when it comes to early rise, it is ischemia modified albumin. The previous answer to this was heart fatty acid binding protein. Heart fatty acid binding protein usually rises between 1 to 3 hours, whereas ischemia modified albumin will be rising in the very first hour. Then is cardiac biomarker of reinfarction after 72 hours. So if he says after 72 hours, then it is okay. Then it is CPKMB, creatine phosphokinase myocardial band. And if he says what is the investigational choice for diagnosis of myocardial infarction, then my answer would be given as troponin I or troponin T. And if he says what is the first investigation to be done in any case of MI, then the first investigation in any case of suspected myocardial infarction would be answered as ECG, because the findings would be not only telling you that it's an MI, it will also tell you whether it is ST or non-ST elevation MI, because the treatment for both of them is also different. As far as the treatment of choice for ST elevation MI is concerned, we would like to take up the patient in the cath lab, do a balloon angioplasty and destroy the thrombus bang in the middle of the coronary artery, which is called as primary percutaneous coronary intervention. So if he says first medical contact to balloon time, then we should be doing the procedure preferably within 90 minutes. The objective is to improve the cardiac perfusion. And if I'm working at a smaller place where cath lab facility is not available, then we will do thrombolysis. If he says the word window period for thrombolysis, then do remember the word window period, if it is written, that means that we are calculating everything from symptom onset and not from the patient's arrival to the hospital. So the window period for thrombolysis should be answered as within 12 hours. Yes, guys, for stroke, it is 4.5 hours. For stroke, it is 4.5 hours. The upper limit is obviously 6 now in stroke also, but for myocardial infarction, it is 12 hours. That's because the heart is more resistant to hypoxia. I would like to mention here only that if he says for acute ischemic stroke, what would be the recommended window period, though I'll discuss that in the neurology section as well. But then sometimes, due to oversight, error can happen. So I need to clarify here only that in stroke, the guidelines are ideally 4.5 hours, upper limit of 6 hours. For heart is 12 hours. If I'm working at a place where cath lab facility is not available and I have to go ahead and do a thrombolysis, then this should be started within 30 minutes. So there are two separate aspects which I have highlighted before you. One is, in fact, I'll just write this part for stroke once again because this was comparison sake. So I'll write it a little separately because the data should be very clear. You can see from the representation at the moment that window period for thrombolysis for 12 hours and door to needle time both do not mean the same. When I say window period, means it can be done up to how much time from the symptom onset. So from symptom onset up to 12 hours, the myocardial tissue is salvageable. But once the patient establishes contact and comes to the hospital, I should be starting it within 30 minutes two separate aspects, guys. I said one, this can be done. I mean, the procedure is effective up to, that is 12 hours, and patient comes in that 12 hours period anytime to me. Within 30 minutes, I should be starting the procedure. As far as acute ischemic stroke is concerned, as I've highlighted, and I'll just say it once again, all cases of AIS, preferably within the 6 hours of the symptom onset, ideally 4.5 hours, fibrinolysis or thrombolysis should be initiated. The drugs which are approved for management of acute ischemic stroke are alteplase and tenecteplase. Now, there's another term that has been asked in FMGE exam, that is rescue percutaneous coronary intervention. So, rescue PCI is where there is a failure of thrombolysis. I mean, the concept was, when would you like to do a rescue percutaneous coronary intervention? Because traditionally we are going for a primary PCI in a patient. So failure of thrombolysis. And this definition would be like, what do you mean by the word failure is that there's a less than 50% decrease. Like suppose ST elevation was 4 millimeter, should decrease to 3, 2, 1 like that. But here there's a less than 50% improvement in the ST segment changes. So 90 minutes after fibrinolysis, that is when we say this is a failure of the process of fibrinolysis, and we need to rush the patient to a cath lab facility where a rescue percutaneous coronary intervention would be done.